if we are talking about myocardial revascularization in heart failure patients, especially if we are talking about PCI patients, we have to talk about two different scenarios. First of all, a heart failure patient, always a HFrEF patient, is a high-risk PCI patient, or sometimes in clinical daily practice, these patients even present with a cardiogenic shock to our hospitals. And if we're doing PCI, myocardial revascularization in these patients, we have different devices for percutaneous mechanical circulatory support that are helpful to facilitate the intervention. Unfortunately, in Europe, unlike to Vietnam, intra-aortic balloon pump isn't available anymore. We have to focus on impeller most of the times and have for specific situations also VA ECMO support. In this talk, I'm focused on the impeller CP Smart Assist system, which is basically a pump that is introduced in the left ventricle over a common femoral artery axis. It's basically 14 French and takes the blood with a rate of 4 liters per minute out of the left ventricle into the aorta. And the pathophysiology behind the system is that we unload the left ventricle, increase coronary perfusion, and thereby prevent myocardial stunning during the procedure and also reduce acute kidney injury later in these patients. And if you take a look on this vicious cycle you will introduce in your patient, if you're doing PCI in a patient with heart failure, you reduce cardiac output by, for example, prolonged lesion preparation, balloon inflation, rotational atherectomy. You're giving these patients a volume challenge by giving them saline for kidney protection. Also, contrast dye injection increases this volume challenge. And of course, minor or major complications can occur, for example, dissection or perforation of coronary vessels. And this all leads to a reduced cardiac output with myocardial dysfunction. And basically, ischemia is the end and leads to this vicious cycle of progressive myocardial dysfunction. And at the end, also to circular depression and deterioration of our patients. If we put in a device for mechanical support, we antagonize this vicious cycle. We increase, as I said, cardiac output by unloading the left ventricle, decreasing LVEDP in our patients, and then facilitate our myocardial revascularization procedure and thereby address this issue of ischemia and antagonizing this vicious cycle. What kind of data do we have for this kind of procedure? So the PROTECT-2 trial was published 12 years ago in Circulation. Unfortunately, this study was a negative trial, I have to say, because it was stopped for futility. Basically, it compared high-risk PCI patients with an ejection fraction below of 35%, randomized 1-to-1 to intra-aortic balloon pump on the one hand side, or impeller 2.5, which is not available anymore, on the other hand side. And unfortunately, this trial had to be stopped after inclusion of more than 400 patients due to the fact that the primary endpoint was not different between the groups. The primary endpoint was a combined endpoint, very soft, very many clinical endpoints with an endpoint at 30 days, but in a secondary analysis, as I'm going to show you in this slide, post hoc analysis after 90 days, there was a significant difference with approximately 30% relative reduction in MACE compared to intra-aortic balloon pump in favor of these patients that underwent PCI with impeller support. So at the end of the day, this trial was negative, but there was at least a hint that impeller protection in these patients might be beneficial. How can we put this study into context with existing studies dealing with PCI patients, such as Syntax, Freedom Trial, Excel Nobel Trial? First of all, you see that in these larger mega trials, all patients with heart failure have been excluded. The rate of patients with an ejection fraction below 35% was 1 to 3%, so not really significant. And the PROTECT-2 trial, it was 100%. Patients had a much higher Syntax score. And so this study has to be repeated, in my opinion. It will be repeated, as we'll show you at the end of my talk, to finally address this issue. As you might know, 2 years ago, also on the ESC, the revived BCIS2 trial has been published. One study that compared treatment of heart failure patients with an ejection fraction below 35%, randomized to PCI on the one hand side, optimal medical treatment on the other hand side. And unfortunately, after 7 years of treatment, we didn't observe any difference. So is PCI not beneficial for heart failure patients? I would disagree, because there are some critical points of the studies that have to be mentioned, that have to be addressed. For example, there was a critical selection bias. Although this study included 700 patients, which is pretty much at 40 UK sites, it lasted over 7 years. And if you break that down to a rate of patients per site per month per center, it's only 0.2 patients per site per month. So I would say that is not the typical all-comer patient that has been included in this study. Next issue was that only stable patients have been included. Acute coronary syndrome was excluded. Patients have been tested for vitality but not ischemia, which is, in my opinion, an issue. And the most important issue, I would say, that they have not been treated according to standard of care in these days. I mean, we have to evaluate our lesions not only by physiological measurements with IFR or FFR, but especially to optimize our stent implantation with intravascular imaging. That has not been a standard of care and has not been done in this study. And at the end of the day, the patients that didn't underwent PCI at first had a much and significantly higher rate of unplanned revascularization in the control group. So that means that these patients underwent PCI, but just a little bit later. So what kind of study do we have in addition to this BCIS2 trial? We have the PROTECT3 trial, which was a post-approval study. Unfortunately, only a registry, not a randomized study, so we will need PROTECT4 in the future. But this PROTECT3 study shows us what is standard of care in Europe and the US at this moment. And in this study, patients were identified according to the PROTECT2 inclusion criteria and called from now on PROTECT2-like cohort. And if you compare these patients now, you can see the PROTECT2-like PROTECT3 patients on the left-hand side and the historical PROTECT2 patient on the right-hand side, that impeller CP use was much more common. And remember, impeller CP meant 1.5 liters per minute more of support. And interestingly, these patients of the PROTECT3 trial underwent more extensive revascularization. 1/3 of the patients underwent treatment of all 3 vessels. CTOs were much more common in these patients. And also the use of rotational atherectomy was more than 1/3 of the cohort. And at the end of the day, the residual syntax score as a marker, an indicator for completeness of revascularization, could be reduced significantly compared to this historical cohort. And that, at the end of the day, led into, in this not randomized comparison, to an even further reduction of mortality in these patients. So what did this mean for our European guidelines that have been updated in this year, also in September, shown in London? So if you take into account revascularization in chronic coronary syndrome patients, meaning that we are talking about stable heart failure patients, this revived BCIS2 study unfortunately led to a downgrade of the recommendation for PCI in heart failure patients from 2A to 2B. So there is still room for percutaneous coronary intervention, but the guidelines strongly recommend, especially in low-risk patients, CABG. But interestingly, although we don't have any new randomized data, the new guidelines published this year recommend for high-risk PCI and complex coronary artery disease patients with HFrEF the use of mechanical cardiac support, such as the micro-axial flow pump, which is basically the impeller in these days, to minimize the risk of severe complications and to achieve a more complete revascularization. So, as pictures say, more than 1,000 words, if these movies are running. During the check, they were running. Unfortunately, this is not the case. But these would be 3 examples from our hospital that presented with severe heart failure, both gentlemen in their 60s or early 70s with a severely increased left ventricular end diastolic pressure and a very low ejection fraction, also presenting with ischemic cardiomyopathy, moderate to severe mitral regurgitation. And as we don't know what is the best option for these heart failure patients, we randomized both patients, as you will see, to the PROTECT 4 trial, which is ongoing, not only recruiting in the US, but also in many European centers. So if the movies are not running, I would say it's not an issue. We're going to the next slide. Let's skip the movies, it's not an issue. Going to the next slide. When do we need hemodynamic support, and how do we decide in our clinical daily routine when to use these devices in PCI procedures in heart failure patients? So several parameters have to be fulfilled. First of all, you have to have a patient with complex coronary artery disease, meaning that you have to deal with the left main, maybe the last patent vessel, or you have to be prepared for extensive lesion preparation. Second, hemodynamic compromise. That is something which is very common in heart failure patients. Low ejection fraction, elevated LVEDP. And the third point, which has to be fulfilled, is patient comorbidities, for example, heart failure, as we're talking about now, advanced age, frailty, and all these things. And the fourth point is also you have to take into account its operator skills, but at the end of the day, all these parameters lead to the creation of this so-called CHIP, a complex high-risk indicated procedure patient. And these patients, at least that's my opinion, benefits significantly from hemodynamic support during their procedures. And as you see here in our patients, unfortunately, movies are not running again, but the first patient was randomized to the impeller arm of the PROTECT 4 trial. The second patient was randomized to the conventional arm without impeller. Both patients underwent their procedures, extensive procedures of both vessels. The first patient with intravascular lithotripsy with a shockwave balloon, antegrade recanalization of the LAD-CTO. And thanks to the device, even though we are not able to show the movies, unfortunately, this patient was kept completely stable. But during the procedure, we noticed a loss of pulsatility, which would have meant that the patient would have crushed on the table without the device. And interestingly, the second patient, which was in a comparable clinical fashion, he stayed during the whole procedure without hemodynamic support, also extensive procedure with rotational atherectomy to two vessels with recanalization of the posterolateral branch of the right coronary artery, and this patient was completely stable. So this is one of my final slides. We definitely need another study. This is a so-called PROTECT 4 trial in which both of our patients have been included. And this trial is randomizing patients with an ejection fraction of below 40% to the impeller arm plus CPI or the conventional arm intra-aortic balloon pump, which, as I told you, is unfortunately not available anymore in our home country, unlike here to Vietnam. But we will see what these results will give us as evidence in the future. And this study, fortunately, focused on a primary endpoint, a hard endpoint, as a composite of all-cause death, stroke, LVAD implant, heart transplantation, myocardial infarction, or hospitalization for cardiovascular causes. It basically is a heart failure trial if you take a look at this endpoint. So the potential reasons for a better outcome with percutaneous mechanical circulatory support are that this provides stable hemodynamics throughout the procedure for our patient, even in situations with low flow or slow flow. And it gives us the opportunity for more complete revascularization, as we have seen and proven in the PROTECT 3 trial. What are the potential disadvantages? This is quite obvious. We might encounter vascular excess site and bleeding complications in our patients. But if you address this with careful procedural planning, a controlled puncture by ultrasonography guided pre-closure devices, and this kind of stuff, you will have a very favorable result. And of course, we have to talk about device-associated complications during the further course of these patients on the ICU, such as limb ischemia or hemolysis, which is not an issue in these protected PCI patients. And dear ladies and gentlemen, dear colleagues, to summarize my talk, PCI in HFrEF patients is complex, and I hope I could convince you, needs a careful case preparation. And if several high-risk criteria are met, such as complex coronary artery disease, impaired hemodynamics, and complex comorbidities, and femoral access is feasible, this is very important. Intraprocedural mechanical support with an impeller or an intra-aortic balloon pump might play an important role to provide a safe and effective, and especially a complete revascularization in these patients. Thank you very much for your kind attention.